Welcome to the deep dive. We have a highly specific, custom-tailored journey planned for you today.
Yeah, if you are a medical student, a junior doctor, a public health trainee, or a practicing clinician, you are in exactly the right place right now.
We are going to build some incredibly clear conceptual frameworks around two massive pillars of modern public health strategy.
And our sources today are drawn directly from the Oxford textbook of global public health.
Right. Specifically, we are looking at Chapter 11.4 on population screening and Chapter 4.3 on new communication technologies.
Which might seem like disparate topics at first glance, but
Yeah, they really aren't. And this is designed to be a companion to your active reading of these chapters, by the way. We aren't going to just read the textbook to you.
no, absolutely not. We are going to extract the mechanisms, the reasoning, and the systems level thinking that you actually need on the wards and in policy meetings.
Because when we approach public health, there is this tendency to compartmentalize our interventions, right?
Oh, completely. We put physical, biological interventions in one box, and we put communication or behavioral strategies in a totally different box.
Exactly. But by examining these two chapters side by side, we can observe how they operate on very, very similar epidemiological principles.
Both chapters fundamentally deal with how we identify risk, how we deploy interventions across populations rather than individuals, and
And how those interventions impact the broader healthcare system. We are talking about the framework of risk, moving to exposure, leading to an outcome, prompting an intervention, and finally resulting in a system impact.
to help anchor these dense concepts as we move through the material, we want to establish two overarching metaphors for you to keep in the back of your mind today.
Right, so for our first half on population screening, I want you to think of screening as an early warning radar, and the act of prevention as upstream engineering.
Upstream engineering. I love that.
You aren't just reacting to the floodwaters pouring into your emergency department. You are trekking miles upstream to inspect the structural integrity of the dam.
And for the second half of our deep dive, dealing with new communication technologies, the metaphor is the digital agora.
The Agora.
Yeah, in ancient Greece, the agora was the central public square, the physical space where citizens gathered, traded goods, and, most importantly, shared ideas and shaped the narrative of their society.
And today, that public square is entirely digital.
Exactly. And in this digital agora, we are finding that information, both protective and deeply harmful, spreads exponentially faster than any biological disease.
Okay, let's unpack this. I want to start by looking at that first framework, the anatomy and illusion of population screening.
It's a huge topic.
It is. And I know a lot of clinicians use the words testing and screening interchangeably on a daily basis.
They do all the time.
But the textbook makes it very clear that this is a dangerous conflation. Let's ground this historically for a second. Where did the modern concept of population screening actually originate?
Well, the modern architecture of screening really took shape in the 1940s. A prime example is the deployment of mass miniature radiography, or MMR, for tuberculosis.
Right, around 1946 or so.
Exactly. Effective pharmacological treatments for TB were finally becoming available. Public health officials realized that if they could identify the disease early, before massive pulmonary cavitation occurred.
They could actually treat it and save lives.
Yes. So they deployed mobile X-ray units to factories, town squares, schools. It was this visible, massive public health triumph. Find the disease, treat it, cure it.
But that success created an enduring legacy that sometimes blinds us today, doesn't it?
It really does. It established the paradigm that earlier is always better, which we will see is not always mathematically true.
That brings us to the crucial differentiation we need to make right out of the gate. McKeown formalized this definition in 1968. He stated that screening specifically targets asymptomatic, presumed healthy populations. Why is that distinction so vital for a junior doctor to understand when they're communicating with a patient?
What's fascinating here is how the clinical reasoning fundamentally shifts based on that definition. Consider a scenario where you are managing a diabetic patient in your clinic.
Okay.
You systematically examine their retinas annually for signs of diabetic retinopathy, or you use a monofilament to check their feet for peripheral neuropathy.
Sure, standard protocol.
But that is not screening. That is testing or case finding or opportunistic testing. You are applying a diagnostic tool to a patient who already has a known underlying pathophysiological condition.
A condition that heavily elevates their risk for a specific complication.
Precisely. Screening, by strict definition, is an unsolicited public health service offered to a defined population who do not perceive themselves to be at risk.
We're talking about mailing letters to thousands of perfectly healthy-feeling 50-year-olds.
Exactly, inviting them to come in for a mammogram, a colonoscopy, or a routine blood test.
You are reaching out to the presumed healthy. You are casting that early warning radar over a completely quiet population.
And this is where we run into the mathematical reality of screening.
Which is where the illusion often shatters for clinicians and patients alike. Because there is a deeply ingrained assumption in the medical community that when we pick a screening test, high sensitivity is the absolute most important metric.
Because we simply cannot afford to miss a single case of disease, right? That's the mindset.
Right. The human instinct driving that assumption is completely understandable. As a clinician, your worst fear is sending a sick patient home with a false reassurance.
You want a test that catches every single true positive.
However, the mathematics of epidemiology dictate that in low-prevalent settings, specificity, the ability of the test to correctly identify those without the disease, becomes the critical bottleneck.
A highly sensitive test deployed in a population where the disease is incredibly rare will inevitably bury the healthcare system under a mountain of false positives.
The textbook uses beta thalassemia screening as a primary example to illustrate this. Could you break down the clinical markers they use here and then kind of walk us through the math?
Sure. Let's talk about the mean cell hemoglobin, or MCH, as a proxy.
Why use that specific biomarker?
Well, beta thalassemia is an inherited blood disorder that reduces the production of hemoglobin. When public health programs screen for the carrier state, they don't jump straight to expensive genetic sequencing for millions of people.
That would bankrupt the system instantly.
Exactly. They need a simple, cheap proxy. So they look at mean cell hemoglobin, the average amount of hemoglobin in a single red blood cell. A low MCH is a strong indicator of the carrier state.
The textbook discusses using an MCH cutoff of 27 picograms, I believe.
Yes. If a patient's MCH is below 27, they flag positive on the screen.
So we have our test. Now let's apply the math. Let's say we deploy this MCH test in a high prevalence setting, like a specialized hematology clinic in London where a lot of patients already have a family history or relevant symptoms.
In that high prevalence setting, the test performs beautifully. Let's say the prevalence of the carrier state in that specific clinic is very high.
Okay.
The test might show 100% sensitivity, it catches every carrier, and the positive predictive value, the PPV, sits around 77.4%.
The PPV is the crucial number for the patient sitting in front of you.
It is. It answers the question, given that my test result is positive, what is the actual probability that I have the disease?
So in this high prevalence clinic, a positive result means there is a roughly 77% chance they are a carrier.
Which is highly actionable clinical information.
But I want to take that exact same test, using that exact same 27 picogram cutoff, with the exact same inherent sensitivity and specificity.
And deploy it as a general population screen.
Yes. In a region where beta thalassemia is very rare, let's say the population prevalence drops down to just 1%.
This is where the mathematical trap springs. To understand this, let's look at a hypothetical population of 10,000 asymptomatic people.
Okay, 10,000 people.
With a 1% prevalence, 100 people actually have the carrier state, and 9,900 people are perfectly healthy.
Right.
Now, let's assume we are using a theoretical test that is incredibly robust, say 95% sensitivity and 95% specificity.
95% accuracy sounds fantastic to a patient.
It does, but let's run those 10,000 people through the radar. First, the 100 people who actually have the condition.
Okay.
The test has 95% sensitivity, so it correctly identifies 95 of them. We have 95 true positives.
Makes sense.
Now, we run the 9,900 healthy people through the test. The test has 95% specificity, meaning it correctly identifies 95% of them as healthy.
But that leaves a 5% error rate.
On a massive number of people, 5% of 9,900 is 495 people.
So the test throws a false alarm for 495 perfectly healthy people.
Correct. Now put yourself in the shoes of the clinician. Your clinic receives all the positive results from this screening drive.
Okay, I'm looking at my list.
You have 95 true positives, and you have 495 false positives. Out of all the people who tested positive, 590 people in total, only 95 actually have the condition.
Wow.
If we calculate the positive predictive value 95 divided by 590, We get about 16.1%.
That is the staggering reality of population screening. If your patient gets a positive result on a test that is 95% accurate in a low-prevalence population,
There is less than a 17% chance they actually have the disease.
over 80% of those positive results are completely false alarms. How does a junior doctor actually navigate that conversation?
Yeah.
Imagine a patient demanding a full-body MRI because they want to catch everything early.
It requires immense clinical tact and a solid grasp of these very concepts. You have to explain the concept of the incidentaloma.
The incidentaloma, I love that term.
If you put a healthy 30-year-old through a full-body MRI, the sheer sensitivity of the machine guarantees you will find a shadow, a cyst, or a benign node.
You're going to find something.
Exactly. And you have to explain to the patient that finding that shadow triggers a cascade. It triggers anxiety. It triggers invasive biopsies that carry real risks of infection or bleeding.
And it triggers further radiation exposure from follow-up scans.
You have to gently shift their perspective from catching everything early to understanding that looking too closely at a healthy system often creates illness where none existed.
That perfectly illustrates the transition from the intervention to the system impact. When we talk about an 84% false positive rate across a national population, the collateral damage is immense.
It really is.
You have the severe psychological harm inflicted on healthy individuals who spend weeks believing they have a life-threatening disease.
You have the resource drain of confirmatory tests, the surgical suites booked for unnecessary biopsies.
And the clinical bottlenecks. You end up clogging the healthcare system with healthy people, which actively delays care for the patients who are genuinely symptomatic and sick.
Because of this massive potential for system-wide harm, public health governance cannot simply roll out a national screening program just because a biotechnology company invented a novel, highly sensitive diagnostic assay.
Here's where it gets really interesting. There must be a rigorous framework of justification.
Yes. This brings us to the Wilson and Youngner criteria, published in 1968 for the World Health Organization,
Which were later adapted and elaborated upon by bodies like the UK National Screening Committee. It is an exhaustive checklist of ethical, economic, and clinical hurdles that must be cleared before a population is invited to be screened.
The textbook outlines several of these criteria. It isn't just about the test itself, it's about the entire infrastructure surrounding the disease.
The condition has to be an important health problem. The natural history of the disease, how it progresses from a latent asymptomatic phase to declared clinical illness, must be adequately understood.
The natural history criterion is paramount. If we find a microscopic cellular abnormality, but we don't know if that abnormality will stay dormant for 40 years or aggressively metastasize in 6 months.
We have absolutely no business screening for it.
Furthermore, there must be a simple, safe, precise, and validated test acceptable to the population. But perhaps the most rigid barrier to entry is the requirement for an effective treatment.
Right. Screening a population for a devastating neurological condition for which there is absolutely no disease-modifying therapy is ethically fraught.
You are essentially diagnosing a future tragedy without offering a solution, converting a healthy person into a terrified patient years before they would have naturally developed symptoms.
The UK National Screening Committee also heavily emphasizes opportunity cost. The cost of the screening program must be economically balanced in relation to expenditure on medical care as a whole.
Because you are allocating incredibly scarce health resources, nursing hours, laboratory reagent supplies, administrative budgets.
The evaluation of opportunity cost requires us to look at metrics like Quartile's quality-adjusted life years and Daly's disability-adjusted life years.
A QALY measures the value of health outcomes. One QALY equates to 1 year in perfect health. A Daly measures the burden of disease. One Daly represents 1 year of healthy life lost to disease or disability.
When we evaluate a screening program, we have to model how many dailies it will avert versus how much it will cost.
Right. If a national screening program is immensely expensive but only generates a tiny fraction of a QALY per person screened, it means you are actively draining financial resources away from other essential medical services.
Like emergency trauma care or maternal health.
Exactly. Services that are far more cost-effective.
The textbook highlights a fascinating example of where this economic and epidemiological modeling gets incredibly tricky and how quickly assumptions can become outdated. Let's look at the abdominal aortic aneurysm, or AAA, screening programs.
The AAA screening saga perfectly illustrates the fragility of these predictive models. An abdominal aortic aneurysm is a swelling of the main blood vessel leading away from the heart.
If it ruptures, it is catastrophic, and often fatal.
Screening involves a simple, non-invasive ultrasound of the abdomen in older men. But the original randomized controlled trials that justified this screening were designed and conducted years ago.
During an era when smoking rates among men were significantly higher.
And smoking is a massive driving risk factor for developing in AAA.
So the initial economic models assumed a high prevalence of the condition based on those historical smoking rates.
Precisely. The models predicted that the screening program would find a large number of aneurysms, surgically repair them, and save enough lives to justify the massive cost of scanning every older man in the country.
However, public health had already been conducting upstream engineering regarding tobacco.
By the time the national AAA screening program actually rolled out in the UK, decades of aggressive anti-smoking campaigns, taxation, and bans had caused population smoking rates to plummet.
Consequently, the actual prevalence of AAA in the modern population was far lower than the trials had predicted.
And the economic model completely falls apart at that point.
The program still cost the exact same amount of money to run. You still have to pay the sonographers, buy the ultrasound machines, administer the invitations.
But because the prevalence dropped, you were finding far fewer aneurysms and preventing far fewer ruptures. The cost per QLOY gained skyrockets.
It demonstrates that a screening program is not a static intervention. It exists within a dynamic ecosystem of shifting population behaviors.
When the fundamental risk factors in a population change, the justification for the screening program must be aggressively reevaluated.
But the textbook notes that it is incredibly difficult to halt a screening program once it has been integrated into society. This introduces what Raffel and Gray termed the popularity paradox.
Yes.
We see this immense societal push for screening. Politicians absolutely love announcing new screening programs because they are highly visible interventions.
Setting up mobile screening units in a supermarket parking lot or cutting the ribbon on a new imaging center looks like tangible action. It proves they are fighting the disease. The popularity paradox is one of the most counterintuitive and profound psychological phenomena in public health. The paradox states, the more people a screening program harms through overdiagnosis and overtreatment, the more popular that program becomes among the public.
To understand this, we must clearly define overdiagnosis.
Overdiagnosis occurs when a screening test correctly identifies a true biological abnormality, like a tiny indolent tumor, but that abnormality would never have caused the patient's symptoms or shortened their natural lifespan.
The patient would have eventually died of old age or a different cause, completely unaware of the tumor. Let me play devil's advocate here, because this is where clinical realities clash with patient emotions.
Go for it.
If a patient goes in for a prostate screening or a breast cancer screening, and the doctor finds a tumor, operates on it, and the patient goes on to live another 20 years.
But that patient is going to fiercely believe the screening program saved their life.
Exactly. If they feel saved, who are we as public health practitioners to tell them they are victims of an illusion? Isn't that incredibly paternalistic?
It is a delicate ethical tightrope. On an individual human level, you cannot fault the patient for feeling overwhelming gratitude. Their subjective reality is that they survived cancer.
Right.
But as a public health practitioner, your duty is to the population level, where you must evaluate the objective harm. Let's trace the trajectory of that overdiagnosed patient.
Okay.
Because the tumor was found, they undergo a radical prostatectomy or a lumpectomy. They are subjected to general anesthesia, potential surgical complications, radiation therapy, or hormonal treatments.
They may suffer lifelong severe side effects like incontinence or impotence.
They endure all of this physical and psychological trauma to remove a lesion that was never actually a threat to their life.
So the paradox is that they become the fiercest, most vocal advocates for the very program that unnecessarily subjected them to severe medical harm.
They join advocacy groups, they testify before politicians, demanding that the screening program be expanded.
Completely unaware that they were victims of overdiagnosis.
The sheer volume of these passionate, subjective testimonies drowns out the cold, statistical reality of the epidemiologists pointing to the systemic harm. That is why stopping a popular screening program is politically perilous.
However, the textbook does provide contrasting case studies on halting harm. The divergence between how Japan handled child neuroblastoma and how Denmark handled tuberculosis is incredibly instructive.
Let's start with the Japanese neuroblastoma program.
How did they manage to shut it down?
In 1985, Japan instituted a nationwide screening program for infant neuroblastoma, a type of nerve tissue cancer. They tested the urine of 6-month-old infants for specific biochemical markers. It was widely adopted.
Okay.
However, by 1990, robust international evidence began to surface, indicating that the program was not reducing neuroblastoma mortality rates.
Furthermore, it became evident that the screening was causing significant harm.
Infants were undergoing major abdominal surgeries and chemotherapy to remove benign tumors that possessed a natural history of spontaneous regression.
Meaning the tumors would have disappeared on their own without any intervention.
That is the ultimate nightmare scenario of overdiagnosis inflicting chemotherapy on healthy babies.
But they successfully halted it.
They did. By 2004, a national scientific committee rigorously reviewed the epidemiological evidence and decisively recommended halting the program.
They succeeded for three key reasons. Right.
First, the scientific media accurately reported the data without sensationalism. Second, the public and parents were effectively educated about the complex pitfalls of cancer screening and the reality of tumor regression.
And third, crucially, there were no deeply entrenched, well-funded advocacy or corporate groups fighting to maintain the status quo.
The evidence led, and the policy followed.
But then we look at Denmark and their tuberculosis screening, and we see the exact opposite outcome.
The Danish TB stations are a masterclass in organizational inertia. During the height of the TB epidemic, mandatory chest X-ray screening was a vital tool.
But as public health improved and treatments advanced, TB was effectively eradicated as a mass public health threat in Denmark.
Yet it took 20 years after the disease was controlled before the government finally closed down the TB screening stations.
20 years of operating a radar when the enemy fleet had already surrendered.
Exactly. And the private sector was even worse. The textbook notes that large corporations, such as the Carlsberg breweries, continued to mandate chest X-rays for all newly employed personnel for decades after it was clinically justified.
For all those years, these mandatory X-rays were doing absolutely nothing to prevent the spread of tuberculosis because the disease wasn't there.
But they were systematically exposing thousands of healthy young adults to unnecessary ionizing radiation.
And even a small dose of radiation carries a stochastic risk of inducing genetic mutations and cancer down the line. It perfectly demonstrates how deeply entrenched beliefs,
like X-rays keep our factories safe.
Yeah, that and bureaucratic inertia can make stopping a demonstrably harmful program nearly impossible.
It underscores the necessity of building sunset clauses or mandatory review periods into any public health intervention. You must have a pre-planned off-ramp.
Before we transition our framework, let's look at how these screening principles apply across the span of human life. The textbook discusses life course epidemiology.
Let's examine the antenatal and newborn screening phase.
In the antenatal and newborn phase, the focus shifts heavily toward genetic and congenital screening. We are looking for conditions like sickle cell disease, cystic fibrosis, and Down's syndrome.
The primary clinical goals here are twofold. Either allowing for immediate, life-saving early intervention, such as specialized diets for metabolic disorders, or providing parents with critical information to make informed reproductive choices.
However, this is arguably the most ethically fraught arena in all of public health.
The textbook explicitly mentions the dark historical shadows cast over this field.
It does, and we must acknowledge it. The textbook references the history of eugenics, the early 20th century social movements, and state-sponsored policies aimed at improving human hereditary traits.
Often through forced sterilization or the elimination of marginalized groups. Because genetic screening touches upon the very biological makeup of future generations, it operates in the long shadow of that history.
This is why the standard for informed consent in antenatal screening is exceptionally rigorous. It can't just be another routine blood draw that the patient barely notices.
Absolutely not. Prospective parents must fully comprehend what the test is looking for. They must understand the nuanced difference between being an asymptomatic genetic carrier versus having a child who will express the severe disease phenotype.
Most importantly, they must be assured that participation is entirely voluntary.
And that whatever reproductive decision they make based on the results will be supported by the healthcare system without coercion. The screening must serve the autonomy of the family, not the demographic goals of the state.
As we move further down the life course into adult screening, the ethical dilemmas shift from genetics to sheer resource allocation.
The reality of cervical cancer screening provides a stark example of the massive systemic effort required.
The textbook cites a profound analysis by Raffel from 2004, which looked at clinical records in Bristol.
Raffel's analysis is vital for understanding the scale of adult screening. When we look at a successful, well-organized cervical cancer screening program which uses pap smears or HPV testing to find precancerous cellular changes, The numbers are astronomical.
To prevent one single death from cervical cancer, 1,000 women must be screened regularly, coming into the clinic every few years for 35 years.
1,000 women monitored for over 3 decades to save one life.
And we must look at what happens to the other 999 women.
For that one life saved, over 150 of those women will receive an abnormal result at some point, causing immense psychological anxiety and fear of cancer.
Over 80 of them will be referred for further invasive investigations, like colposcopies or biopsies.
And over 50 of them will receive physical treatments, excision or ablation of cervical tissue.
Many of whom had high-grade anomalies that, in reality, would have naturally regressed and never developed into invasive cancer.
You have to treat the many to save the few. You subject dozens to invasive procedures and hundreds to anxiety just to ensure that the one woman whose lesion would have become lethal is caught in time.
That is the fundamental, inescapable trade-off of population screening.
It is the ultimate test of the system's capacity to balance profound individual benefit against widespread, low-level population harm.
We have spent a lot of time analyzing how we deploy early warning radars over the physical body to detect hidden biological risks. But what happens when the risk isn't biological, but behavioral?
What happens when the exposure isn't a pathogen, but a narrative?
Exactly. Let's bridge our framework over to our second source, Chapter 4.3, and look at how public health scans the digital landscape.
If we connect this to the bigger picture, this requires a complete paradigm shift. If population screening is the physical intervention targeting the body's hidden diseases, then communication strategy, particularly via social media, is the digital intervention targeting the population's behaviors, beliefs, and health literacy.
We are still managing populations and probabilities, but the vectors have changed.
The same way we use physical tests as radars for disease, we are now utilizing digital platforms as early warning radars for emerging public health trends, vaccine hesitancy outbreaks, and behavioral shifts.
Welcome to the Digital Agora. I remember a time when public health communication was incredibly simple. The CDC or the Ministry of Health would write a press release, update a static web page, and wait for the news anchors to broadcast it at 6 p.m.
That was the era of Web 1.0.
The textbook describes it as a vertical, top-down model. But the shift to Web 2.0 has fundamentally changed the architecture of communication. How does the shift to peer-to-peer horizontal networks alter our strategy?
The Web 1.0 model assumed a passive population. The institution spoke and the public listened. Web 2.0 shattered that dynamic.
The architecture is now horizontal, participative, and user-generated.
People are no longer just passive consumers of health news. They are active curators, creators, and distributors. A localized rumor about a vaccine side effect generated by a single user on a Facebook group can be shared horizontally across peer networks, reaching millions of people before a public health institution is even aware the rumor exists.
The institution is no longer the sole gatekeeper of authority.
To operate in this chaotic space, the textbook suggests that practitioners need to ground themselves in the theories of new media. We can't just launch a Twitter account and hope for the best.
We have to understand why people interact with health information online. Let's unpack selective processing and uses and gratifications theory.
These theories are critical because they dismantle the idea that people absorb all information equally. Selective processing dictates that individuals are exposed to a massive fire hose of daily data, but they actively filter it.
They selectively seek out, pay attention to, and remember information that confirms their pre-existing intrinsic beliefs and attitudes, while ignoring or instantly forgetting information that challenges them.
The psychological foundation of the echo chamber.
Exactly that. Uses and gratifications theory takes it a step further. It posits that people actively choose specific media to fulfill specific psychological needs.
A patient recently diagnosed with a chronic illness might bypass official institutional websites entirely and seek out a patient-led subreddit or a TikTok community.
They aren't just looking for clinical data. They are using the media to gratify a need for social support, emotional validation, or localized practical advice from peers who are living the exact same experience.
Which leads us directly into channel complementarity theory. I find this one fascinating because it challenges the assumption that digital media is making traditional media obsolete in the health space.
Right.
Channel complementarity theory observes that new digital media does not replace traditional media, it compounds it.
An individual who is highly health conscious and reads traditional print health magazines or watches medical documentaries on television does not abandon those habits when they purchase a smartphone.
Instead, they use the smartphone to seek out even more health-related social media, complementing their traditional media intake. The health-active individual leverages every single channel available to them to build a comprehensive picture of their health.
But if new media usage simply mirrors traditional media usage, then we are looking at a massive systems-level problem. The inequalities must mirror each other as well.
This is the crux of the issue, the digital divide. The populations who are historically disenfranchised, those lacking geographic access to clinics, lacking health insurance, or lacking health literacy,
Are the exact same populations who lack access to high-speed internet, modern smartphones, and digital literacy training.
If a public health department blindly assumes that technology is a universal equalizer and launches a sophisticated, data-heavy smartphone app for diabetes management, they risk actively widening the health disparity gap.
Because the wealthy, health-literate populations adopt the app and improve their outcomes, while the marginalized populations are left further behind.
The people who need the intervention the most are structurally excluded from accessing it. We risk perpetuating profound health inequities under the shiny guise of technological advancement.
Technology amplifies existing social structures. It does not automatically dismantle them.
We have to look at how these tools are actually being deployed in the field. When used strategically, there is a bright side. Social media can act as an incredibly agile tool for public health intervention.
The textbook provides some vivid case studies. Let's look at information dissemination during crises. The WHO's use of Twitter during the H1N1 pandemic was a watershed moment.
During the H1N1 influenza pandemic, the World Health Organization realized that waiting for daily press briefings was too slow. The virus and the fear surrounding it were moving faster than traditional media cycles.
By utilizing Twitter, the WHO bypassed the traditional media gatekeepers.
They were able to push real-time, bite-sized updates, epidemiological data, and travel advisories directly to a global audience instantly.
It allowed them to control the narrative tempo and inject credible data directly into the digital agora as the crisis evolved hour by hour.
And beyond just broadcasting crisis updates, we see digital platforms being used to build social capital and drive persuasion. The National Heart, Lung, and Blood Institute launched the Heart Truth campaign on Facebook.
This wasn't just a digital billboard.
The Heart Truth was a masterclass in utilizing the horizontal nature of Web 2.0. The public health officials didn't just lecture women about cardiovascular risk factors, they built a participatory community.
They used interactive digital tools, allowed women to share their own personal stories of heart disease, and fostered peer-to-peer emotional support. They transformed a clinical warning into a social movement.
Similarly, the textbook highlights MTV and the Kaiser Family Foundation creating the Think HIV, This Is Me campaign. They avoided the traditional route of hiring actors or using sterile clinical messaging.
They recognized that to influence youth behavior regarding sexual health, the message had to be perceived as authentic.
They leveraged established youth video bloggers, early influencers, to talk directly to their cameras about how HIV was impacting their lives, their friends, and their communities.
It was raw, user-generated content that resonated deeply with the target demographic because it utilized the native language and format of the platform.
We also cannot ignore the impact of mHealth, or mobile health, particularly in resource-poor global settings.
The textbook details Project Masialuk in South Africa and Text to Change in Uganda. These initiatives utilized simple SMS text messaging for HIV education and testing encouragement.
These projects are brilliant examples of navigating the digital divide. The organizers recognize that while broadband internet penetration might be extremely low in rural African regions,
mobile phone penetration, basic cellular devices capable of sending texts was incredibly high.
They didn't build a complex app. They met the population exactly where they were.
It is the digital equivalent of upstream engineering.
Absolutely. They intervened before the risk behavior occurred by pushing accessible, culturally competent education and reminders for clinic appointments through a device the patient already held in their hand.
It bypassed geographic and infrastructural barriers using the simplest available technology.
We've explored the bright side, the strategic deployment of these tools, but we must pivot our radar toward the unregulated dangers of the digital agora, the dark side.
So what does this all mean? This is where the platforms themselves become vectors for disease.
The dark side is where the financial architecture of the digital platforms directly conflicts with public health. We have to analyze the algorithmic amplification of harm.
Social media algorithms are not neutral sorting mechanisms.
They are proprietary codes designed with a single overriding objective to maximize user engagement and keep eyes on the screen for as long as possible to generate ad revenue.
And extreme, emotionally charged, or controversial content drives far more engagement than calm, nuanced clinical information.
The textbook cites a deeply troubling study regarding YouTube. Researchers analyzed what happens when users search for content related to anorexia and eating disorders.
The algorithm heavily favored, highly rated, and aggressively recommended pro-anorexia videos, content created by users that glorified starvation, shared techniques for hiding weight loss, and actively encouraged the eating disorder.
These harmful videos were pushed to the top of the feed, overshadowing informative clinical videos created by medical professionals designed to help people recover.
The algorithm is actively identifying vulnerable individuals, searching for help, and feeding them the digital equivalent of a pathogen because it keeps them clicking. That is a systemic public health threat.
But it's not just the algorithms, it's the corporate nudging. The food and beverage industry has recognized the power of the digital agora and weaponized it to target youth.
The textbook calls out massive conglomerates like Coca-Cola and Cheerios specifically. The strategy has evolved far beyond running static banner ads on a website.
They utilize interactive storytelling to weave their products into the fabric of social interaction.
Let's break down that Cheerios campaign. They use the tagline, "Your moments, our timeline." The story of Cheerios, as told by you.
It is a brilliantly insidious marketing strategy. They are co-opting the language of community building. They invite users to submit their own family photos and memories involving the cereal.
Coca-Cola executes a similar strategy, encouraging teenagers to post pictures of themselves drinking Coke to be featured on their massive global Facebook page.
The corporations are not just selling a beverage, they're embedding their highly processed, sugary brands directly into the localized, daily digital identities of children and adolescents.
As a public health practitioner trying to run an anti-obesity campaign, you are entering an arena where the junk food industry spends billions of dollars to optimize these digital nudges, using the best behavioral psychologists in the world.
You are fighting a localized skirmish against a global, algorithmically enhanced marketing machine.
Furthermore, we must address how the interpersonal dynamics of these platforms create direct behavioral harms. Public health must view cyberbullying and electronic aggression not just as schoolyard disciplinary issues, but as critical etiological factors in youth violence and mental health crises.
The statistics the textbook provides on this are harrowing. It's not just kids being mean on the internet. It has severe, measurable epidemiological impacts.
The textbook cites a study by Ybarra and colleagues analyzing the real-world behavioral fallout of online harassment.
The Ybarra study reveals that youth who report being harassed online are 8 times more likely to carry a weapon to school compared to those who do not experience online harassment. Let that sink in. 8 times more likely.
That is a massive behavioral indicator of profound psychological distress. It indicates a complete breakdown of their perceived safety.
The fundamental nature of the digital agora exacerbates this trauma. In the past, if a child was bullied at school, the home served as a sanctuary. The bullying stopped when the school bell rang.
But the anonymity and 24/7 omnipresence of social media mean the harassment follows the child into their living room, into their bedroom, and onto the screen they sleep next to.
The exposure to the psychological pathogen is continuous. This requires clinicians to screen for digital harassment with the same rigor they would screen for physical abuse in the home.
Before we move to our conclusion, we need to examine one final mechanism from the textbook regarding advocacy and social movements. We are going to maintain absolute neutrality here and examine this purely as a case study in communication strategy.
It is essential to view this through an objective structural lens. We are analyzing the mechanism of the tool, independent of any political ideology.
The textbook discusses how social media is utilized to organize resistance against macroeconomic policies.
It utilizes the Occupy Wall Street movement as a prime public health communication example. From our analytical perspective, Occupy Wall Street successfully weaponized the horizontal architecture of Web 2.0.
They utilized digital interactive storytelling to share thousands of localized, highly personal narratives of economic hardship, lack of healthcare access, and housing insecurity.
They bypassed the traditional media networks that might have ignored them and built a peer-to-peer network of grievances.
The movement utilized the digital agora to organize physical resistance against macroeconomic policies, specifically citing the health and social impacts of trickle-down economics and global wealth inequalities.
Regardless of an individual's political stance, the public health takeaway is undeniable. Horizontal, user-generated networks possess the sheer power to mobilize massive, decentralized populations around a shared narrative concerning the social determinants of health.
The digital narrative can manifest as physical, societal action.
It is the ultimate demonstration that public health in the 21st century is about pathogens, policies, and narratives.
So let's pull all of these conceptual threads together and connect both of these halves back to you, the listener. Whether you are managing a physical screening program for a local health trust, debating the Wilson and Jungner criteria for a new genetic test, or you're launching a digital health promotion campaign on TikTok to combat vaccine misinformation.
You are fundamentally managing the exact same elements: populations and probabilities.
You are perpetually trying to find the signal in the noise.
In physical screening, your challenge is locating the true positive biological threat hidden among thousands of false positive alarms, ensuring your intervention doesn't break the system.
In digital communication, your challenge is cutting through the algorithmic echo chambers and the corporate nudging to deliver credible, actionable health information that actually changes behavior.
Understanding communication strategy, media theory, and digital literacy are no longer optional soft skills. They are core clinical and public health competencies required to protect your patients.
Which brings us to our final provocative thought for this deep dive. We've talked about opportunistic testing in the physical clinic, and we've talked about the algorithms scanning the digital agora.
This raises an important question. I want you to consider the convergence of these two chapters. As our digital footprints grow exponentially, capturing every keystroke, search query, and social interaction,
Will social media algorithms become the ultimate opportunistic screening tools?
if a massive tech company's algorithm is sophisticated enough to detect the early linguistic markers of clinical depression in a teenager's timeline, or notice the subtle progressive typing pattern changes indicative of early onset cognitive decline in an older user,
What happens next?
are those tech corporations bound by the ethical rigors of the Wilson and Jungner screening criteria? Do they have a moral or legal obligation to inform the user of this hidden risk? Or is it a violation of privacy to act on unconsented surveillance?
The line between physical screening for biological disease and digital surveillance for behavioral health is blurring at an astonishing speed, and our public health ethics frameworks have not yet caught up to the technology.
That is a profound systems-level question to mull over on your commute or during your next rotation.
Okay, before we sign off, let's lock in a few of these core concepts. If you are on the wards tomorrow and an attending physician decides to grill you on these mechanisms, we want you to be ready. Let's run through a rapid single best answer recall session.
Sounds good.
Question 1. Imagine you are explaining the limitations of a new screening test to a patient. What is the primary epidemiological reason that a test with an impressive 95% sensitivity and 95% specificity can still result in a massive number of false positives? Think about it for a second.
Right, so the mechanism driving that is the low disease prevalence in the asymptomatic target population. When prevalence drops, it heavily degrades the positive predictive value, or PPV, meaning the vast majority of positive flags will be false alarms. You can review the mathematical breakdown of this in Chapter 11.4.
Question 2. You are sitting on a public health governance board evaluating a new screening proposal. According to the UK National Screening Committee, how must the opportunity cost of the program be justified? Take a moment.
The cost must be economically balanced in relation to expenditure on medical care as a whole. You must prove, using metrics like QALIs and DALIs, that the resources consumed by the screening aren't being actively diverted from more cost-effective, vital clinical interventions elsewhere in the system. That framework is detailed in Chapter 11.4.
Question 3. You notice that a patient who religiously reads traditional print medical journals is also highly active on patient-led social media forums. Which media theory explains this compounding behavior? Have a think.
That behavior is explained by channel complementarity theory. It states that new media doesn't replace traditional sources. Health-active individuals use them concurrently to complement their knowledge. You can find the nuances of that theory in Chapter 4.3.
Question 4. What is the specific term for the psychological phenomenon where patients who have been actively harmed by overdiagnosis and unnecessary overtreatment fiercely defend the screening program that harmed them? Think about the term.
That is known as the popularity paradox, coined by Raffel and Gray. The subjective feeling of being saved masks the objective systemic harm. Revisit the ethics of overdiagnosis in Chapter 11.4.
Question 5. When screening a pediatric patient for social determinants of health, you must consider the digital environment. According to the study by Ybarra and colleagues, youth who report being harassed online are how many times more likely to carry a weapon to school? Give it a second.
They are 8 times more likely to carry a weapon. It highlights electronic aggression as a critical etiological factor for violence. Reference Chapter 4.3 for the data on the digital dark side.
And that concludes our time for today. Thank you for joining us on this extensive deep dive into the architecture of population health and the shifting landscape of digital communication.
Keep questioning the systems you work within, and always remember to look upstream. Here are the details of this episode.
New communication technologies, social media, and public health byline. In the digital agora where information spreads faster than disease.